Good morning, respected chairperson, seniors and colleagues. Today I will be presenting a rare case of post-traumatic intraconal orbital abscess managed successfully with medical therapy alone. No financial interest, informed consent has been taken from the patient. So orbital abscess is defined as a localized collection of pus within the orbital tissues, usually developing as a complication of orbital cellulitis. The most common cause worldwide seems to be sinusitis, whereas in India, trauma-related abscess are relatively more frequent. In the first chart shows the Indian etiological distributions where trauma contributes significantly, whereas the second chart compares the global versus Indian trends. These differences highlight the importance of regional context when evaluating the orbital abscess. So the annual incidence is low, around 1.6 to 3.7 per 1 lakh population, but these cases are clinically significant due to high risk of vision and life-threatening complications. Coming to the case proper, a 50-year-old male presented with history of penetrating trauma to the left eye, which was accidental with a tree branch. On the day 3, he developed swelling and pain on the left periorbital region. In the day 4, proptosis and purulent discharge developed. In the day 5, the patient experienced double vision diplopia, and day 6, fever and chills developed. Now, in the past illness, there was no significant history. There was no thyroid disorder or sarcoidosis, no malignancy, lung or prostate cancer, or no periocular malignancies. Coming to the ocular examination, the visual acuity noted was in the left eye, counting fingers and 1 meters, the affected eye. The intraocular pressure measured was right eye 12 millimeters of mercury, and the left eye was non-recordable. The right eye, the extraocular motility was free and full in all directions, whereas in the left eye, there was restricted eye movement in all directions. So coming to the external examination proper, the left eye there was eccentric proptosis noted with severe ptosis. On Valsalva, there was no enlargement in the proptosis elicited. On palpation, tenderness felt. There was raised temperature in the left proptosed eye, and there was no orbital thrill noted in both eyes. Coming to the slit lamp examination, right eye, there was all parameters were normal, whereas in the left eye, there was edema, severe ptosis, eccentric proptosis, and mucopollulant discharge. The partial thickness scleral tear was noted 4 mm superior to the cornea at 12 o'clock position. The cornea was clear, fluorescence and negative. Pupil was round regular, reacting to light. Crystalline lens was found in situ. Coming to the fundus examination, right eye all parameters were normal, whereas in the left eye, choroidal folds were noted. The blood investigation sugar levels were normal in the patient. On gram staining, gram-positive cocaine pairs and clusters were found. On KOH mount, no fungal elements were found. On the culture sensitivity in the disc diffusion method, organisms were found sensitive to linezolid. Other blood workup, the patient was neutrophil counts were raised, thyroid profile was normal, ESR raised, viral markers were negative, renal and liver functions were normal. Coming to the imaging, on the paranasal sinus in the Waters view, there was no evidence of sinusitis or bony deformity. The CT orbit was done. There was irregular heterogeneous soft tissue lesions in the left retroorbital region, possibly in the intraconal space, noted. Then on the contrast and an MRI, there was heterogeneous moderate enhancement which was suggestive of abscess formation in the intraconal space was noted. So my provisional diagnosis, orbital cellulitis with intraconal orbital abscess following partial thickness scleral tear. Here are my differential diagnosis. Then the patient was managed from the broad spectrum antibiotics with IV ceftriaxone 1 gram BD with partial thickness scleral tear repair with 8 vical sutures. From the day 6, after the culture sensitivity report, which initiated the patient on IV linezolid 600 milligram BD for 5 days. Then from the day 8, after 2 days, the patient was subjected to IV methylprednisolone 1 gram OD for 3 days. Here my clinical outcome. In the day 8th, we can see there was improvement in the visual acuity. Coming to 6/24 in the left eye, there was notable reduction in the periorbital edema and the conjunctival chemosis. The ptosis was partially resolved. There was moderate ptosis. There was partial improvement in the extraocular motility and no RAPD, no color vision deficiency noted. The patient was afebrile, WBC trends were normalized. Coming to the day of discharge, on the day 11th, the visual acuity improved to 6/18 in the left eye, and there was proptosis was mildly reduced. There was mild edema, conjunctival chemosis also resolved. There was extraocular motility was free and full in both eyes. Fundus, the choroidal folds also resolved. There was no RAPD, no color vision deficiencies. So, as we know, the case coming to the case discussion, most surgical series and long cases still favor the early drainage for the orbital abscess to prevent complications. However, in recent work has defined indication for conservative managements. There are certain markers which we can note that, like there was initial good vision, limited ophthalmoplegia can go for the conservative managements. What makes our case noteworthy is the intraconal location following the penetrating trauma and successful medical only resolution with targeted IV linezolid and delayed corticosteroid therapy. This suggests that careful selected patients with close inpatient monitoring, proper imaging, and clear culture guidance can sometimes spare the operative drainage. So, to conclude, the orbital abscess is a vision and life-threatening condition where early diagnosis and imaging plays a central role. Culture-guided antibiotics remain the cornerstone. Corticosteroids introduced after infection control is a good approach. And finally, here are my references. Thank you.
Just wanted to know, what did you do with the scleral tear?
Sir, I mentioned, sir, it was repaired with 8O vicryl sutures.
So you are saying medical management.
Sir, initially it was...
Yeah, your topic is you manage the case with medical management.
Yes, sir.
So
And you said you stitched the scleral tear.
So means invasive surgeries I avoided, sir. Means taking the any interventions, surgical interventions, major surgical.
Scleral tear
Yes, surgical
stitched.
approach, sir. Yes, sir. Stitch.
Scleral tear was stitched?
Yes, sir.
Okay. So then it is not a medical management.
Yes.
Thank you.